Following is a presentation related to hepatobiliary disease for a group of Concepts 2 students during the Elimination GI exemplar content. Cholecystitis related to cholelithiasis. So when we talk about hepatobiliary diseases, there are lots of different types of hepatobiliary diseases, lots of different causes, reasons, etc. What we're going to focus on is gallstones because that's the most common one of the most common reasons people are seek treatment in the emergency room, and it's a very common surgery. So that's what we're going to focus on. So cholecystitis is an inflammatory process related to cholelithiasis. So lithiasis actually means stone. So it's inflammation of the gallbladder related to a gallstone. Populations at risk. This is where our F's come into play. So gender, female, native, race of Native American or Northern European. We think of fair-skinned. Family history. I hate to use the other F word, but fat, obesity and hyperlipidemia, and then oral contraceptive and estrogen therapy as fertile. So female, fair, family, fat, and fertile. Those are our 5 Fs. Those can lead to usually gallstones related to cholesterol. We can also have bilirubinate stones, and that's related to biliary stasis. And that can happen from pregnancy, fasting, or prolonged parental nutrition. So patients that have had TPN for a long period of time, or patients who have decreased their fat intake will often have bilirubinate stones as well. So when going through the lecture, we're going to talk about uncomplicated cases, and we're going to talk about complicated cases. So uncomplicated cases are usually treated in the emergency room, and then sent home, and then treated long-term on an outpatient basis, where complicated patients are often hospitalized. So our uncomplicated patients, they have abrupt onset of pain. And this type of pain is actually called something called a biliary colic. I think a colic like a screaming, crying baby. One minute they're calm, and the next minute they're screaming their head off, and then they're calm, and then they're screaming their head off. So it comes and goes. It's caused by a tissue spasm. If you have a stone in your biliary tree, the biliary tree is a muscle. It's actually trying to push that stone out. So the muscles of the biliary tree start to spasm. It causes intense pain, tachycardia, pallor, diaphoresis. It also causes nausea and vomiting. Patients often state that their pain radiates to their back or to their right shoulder. So assessment for a complicated case. We've got nausea and vomiting, and we have the biliary colic as well. But here we have fever and chills because we have an infection. So we've gone from an inflammatory process to a systemic infection. Signs and symptoms of a perforation. So perforation of your biliary tree, bile will then spill out into the peritoneal cavity and cause peritonitis. So signs and symptoms of perforation will look like your patient has peritonitis. If you have a biliary obstruction, if we actually have a stone that is completely obstructing the path of bile being released, the bile, which has the bilirubin in it, then has to escape someplace else. It has to find another way out. So your biliary tree helps bile and bilirubin be processed from your gallbladder and your biliary tree help bile and bilirubin that's been processed from your gallbladder release into your small intestine. So the bilirubin is actually what makes your stool brown. So if we don't have bilirubin in our stool, your stool becomes clay colored. Your urine will become amber because now it has seeped into the blood and your kidneys are processing it. So your urine becomes amber. You become jaundice. Think about all the different places you check for jaundice: eyeballs, buccal mucosa, hands, palms of hands and feet. The biliary obstruction often leads to a perforation and then a vitamin deficiency, specifically fat-soluble vitamins, because your liver is responsible for the fat-soluble vitamins. So diagnostic evaluation of gallbladder disease. The very first thing that we always think about with a gallbladder disease, if we need to remove a stone, is an ERCP. And we've talked about an ERCP in the past. Please remember nursing interventions post-ERCP, vital signs, abdominal assessment. Remember what's important: post-procedure, 24 hours post-procedure, and then 72 hours post-procedure. The 24 hours post-procedure is when we commonly see the side effect or the adverse reaction, the adverse event of a pancreatitis. 72 hours afterwards is when we see infection. Other diagnostics we can use for gallbladder disease is an ultrasound. Ultrasound helps confirm the presence of stones. Patient that's having an ultrasound for a gallbladder disease needs to be NPO after midnight and have a low-fat or a no-fat meal the night before, because fat interferes with the transmission of the ultrasound. An X-ray will also tell us location of stone. And then an oral cholecystograph. Oral cholecystograph, they really don't do those a lot anymore. We see them more on the outpatient side than the inpatient side. It's when they radiate an amount of food and you eat it, and then it's supposed to cause your gallbladder to react or not to react. So nursing interventions for that is they have to be NPO after midnight, and they eat the food once they get there. The more common thing we have is called an intravenous cholangiography, and that is where they actually put dye into the patient, and it allows us to see if they've had a biliary obstruction. Also, the dye is radiated, which will allow us to see if the patient is having some type of reaction to the dye, like they have with the oral cholecystograph. So we're trying to get a reaction out of the gallbladder, basically. Nursing interventions for this, they have to be NPO after midnight. Obviously, have to have an IV so that they can have the isotope and the dye injected, and you should have pain medication on hand, because if your patient reacts, if your gallbladder reacts, they're going to be in excruciating amount of pain, and we want to anticipate that they're going to have biliary colic. Other diagnostic testings, we're going to look at the CBC. We're looking specifically for signs of infection here. If they have a perforation of some type, they will show signs of infection. Liver functions. So when your gallbladder sits up underneath your liver. So if your gallbladder gets full of stones or full of bile because nothing can be expressed, it's like a sponge. It can only soak up so much. So the sponge will then allow the gallbladder that's represented by the full sponge then allows the liquid to go up into the liver. So it will cause problems with the liver. You'll see an increase in your ALT and your AST. Additionally, you may have some problems with your pancreatic functions because nothing is being able to be expressed down the other way. So when you have a backup, it either backs up into the liver and causes problems with your liver, so AST, ALT will be high, or the biliary and the bilirubin and the bile cannot get out, which will cause problems with your pancreatic function. And then bilirubin. So we have total bilirubin. We have direct and indirect bilirubin. Bilirubin is manufactured from your spleen and your liver. Your spleen is responsible for indirect. Your liver is responsible for direct. So if I have a problem on the liver side, such as an obstruction, my indirect bilirubin will be elevated. Excuse me, scratch that. My direct bilirubin will be elevated. My indirect bilirubin will be normal. Let me say that again. If I have a problem with bilirubin escaping, if I have a problem after my bilirubin has all been processed and made, such as a biliary obstruction, my direct bilirubin will be elevated. My indirect bilirubin will be normal. So my direct bilirubin will be elevated. My indirect bilirubin will be normal. Problems with patients. Bilirubin doesn't necessarily indicate that they're going to have increased AST and ALT. They may, but it doesn't necessarily indicate that. So for these patients, the plans and goals are related to nausea, pain management, nausea, alterations in nutrition, and any potential complications. So for pain management, we're going to give a narcotic. Remember, if this is a spasmodic issue, we'll give Bentyl. We can also give antiemetics. Alterations in nutrition. Acute cases, patients are NPO, strict NPO. At home, they will have to have a low-fat, low-cholesterol diet. Most of our stones are made from excessive cholesterol. Potential complications. Biliary obstructions. So remember the signs and symptoms of the biliary obstruction. We've got amber urine, clay-colored stool, jaundice. Perforation, patient will then have peritonitis, which can lead to sepsis. How we fix these gallstones is they'll have a lithotripsy. We talked about lithotripsies during the concept lecture. Lithotripsies are patients will feel some muscle soreness the day after. It's also expected to have bruising at the site. IV sedation, think about nursing measures with IV sedation. So we're going to look at heart rate, blood pressure, etc. It's non-invasive, but they may have some sedation while they're having the test. If they're having large amounts of pain and they need to lay still, which they need to lay very still for a lithotripsy. And then post-procedure, we're going to do diet teaching. So low-fat, low-cholesterol diet teaching. We may also have a patient that has something called a T-tube inserted. So a T-tube here is a tube actually into the biliary tree, which allows the bile to drain into a source outside of the body, like a nephrostomy, or almost looks like a Foley bag. In this picture, the gallbladder has actually been removed. Sometimes the gallbladder is removed, sometimes it's not removed. Anytime you have a patient that has a T-tube, they have a tube coming out of their body. So you want to think about nursing interventions related to skin and nursing interventions related to sepsis, because we don't want that to get infected. Finally, surgical management. We can have an open cholecystectomy where there's a large incision made across the chest. And we want to advance the diet slowly. Pain management is an issue. Turn, cough, and deep breathe in the steno spirometer. We've cut all of their accessory muscles that they use to breathe, so we need to make sure that we decrease the potential for them to get hospital-acquired pneumonia. They'll have incision care. They'll have a large incision, so with staples. We want to make sure that we teach them signs and symptoms of infection and when to return to the physician for testing. They'll also have to return to work in about 6 weeks. A laparoscopic cholecystectomy, the patients may have some gas pain, because what we've done is we've actually inserted air into their abdominal cavity so that they can see the organs. To relieve the gas pain, we want to have early and frequent ambulation. With warm liquids, they shouldn't drink anything through a straw. They shouldn't have anything that's carbonated, etc. And they can return to work. Usually we say 2 to 3 weeks, but sometimes they return to work in as little as 10 days. These patients also have very small incisions that we'll want to teach the patient how to monitor for signs and symptoms of infection. Both patients obviously have had their gallbladder removed, so we need to talk to them about a low-fat, low-cholesterol diet. Their body will still make bile, but because they don't have a gallbladder to store it, often having bile to break down fats is an issue because they don't have the reserves. Thank you.